Good morning, everyone. Hereby I open this academic ceremony in which Fariba Tohidinezhad will defend the academic thesis Prediction Models for Personalized Treatment Delivery in Oncology. May I invite you to present a summary of your study and the conclusions of your thesis.
Thank you very much. Dear the members of the opposition team, colleagues, friends, and family, thank you very much for joining my defense session today. In the next 15 minutes, I will be presenting a summary of my thesis. With the rising incidence of cancer and aging population, more and more patients, their family members, as well as clinicians, face decisional challenges during the treatment trajectory of cancer. In the screening phase, identifying high-risk patients can potentially help to detect cancer at the very early stage. At the time of diagnosis, prediction models can help clinicians with the differential diagnosis of the diseases with overlapping symptoms. When multiple treatment options are available, again, the prediction models that estimate the effectiveness of the treatments can support to select the most appropriate options. During the follow-up, it is important to categorize patients into different risk groups and effectively monitor them for the risk of recurrence and treatment side effects. If a prophylactic treatment is available, again, it is important to make sure that we only use it for the subgroup of the patients who will take the most advantage in terms of risk-benefit balance. And lastly, in advanced stage patients for whom curative treatment is no longer possible, the decision whether to move to supportive care or to use another line of treatment significantly depends on survival prediction. In this thesis, we have investigated the application of clinical prediction models to estimate the risk of radiotherapy-induced side effects, including cardiac toxicity in lung cancer, neurocognitive decline in primary brain tumor, and rectal toxicity in prostate cancer. We further used radiomic-based prediction models for the differential diagnosis of pneumonitis in patients who received immunotherapy. And lastly, two prediction models were developed to estimate the risk of brain metastasis in patients with non-small cell lung cancer and also progression-free survival in rectal cancer. One of the most common performance measures of the clinical prediction models is area under the receiver operating characteristic curve, or the AUC, which quantifies how good the model can discriminate the patients with and without the outcome. The ideal value is 1, which indicates that the model can perfectly separate the two groups, and as the value decreases, we see that more and more patients are misclassified into the other category, and the AUC of 0.5 indicates that the model can perform as good as pure chance. Chapter 3 focuses on prediction of new-onset atrial fibrillation after radiotherapy in patients with non-small cell lung cancer. In this slide, you can see sample patients with a stage 1, 2, and 3 non-small cell lung cancer who are significantly different in terms of the size of the primary tumor and the involvement of lymph nodes. After contouring the whole heart mask and applying the radiotherapy plan, we can see that in all stages, some regions of the heart can be exposed to radiation dose during the treatment. In a retrospective review of 374 patients who received curative intent photon radiotherapy with normal fractionation scheme, we found that 14 months was the most common cardiac event after radiotherapy. Atrial fibrillation is a condition in which the upper chambers of the heart, or the atria, will fail to beat in a regular order. And as the result, the blood will be unable to travel throughout the body effectively. If atrial fibrillation is left undiagnosed and untreated, it can lead to serious complications such as a stroke and heart failure. The gold standard is an electrocardiography in which you can see that the quantitative measures are significantly different from a normal ECG, and the complexes are chaotic and non-predictable. To identify the most radiosensitive cardiac substructure, we automatically contoured 6 regions, including the sinoatrial node and the atrioventricular node as the heart conduction system, and 4 cardiac chambers, including left atrium, left ventricle, right atrium, and right ventricle. And we found that maximum dose to the left atrium was the most predictive dosimetric measure. Additionally, older age, being overweight and obese, current alcohol consumption, previous cardiac procedures, having the tumor in the upper lung lobes, reduced lung function, increased serum creatinine level, and concurrent chemotherapy were also significantly associated with increased risk of atrial fibrillation after radiotherapy. With an optimism-corrected AUC of 0.8, the model showed satisfactory discrimination power. And following strategies can be suggested for high-risk patients. First, regular follow-up with a standard 12-lead ECG after radiotherapy. Second, lifestyle recommendations, including weight management, moderation of alcohol consumption, and light physical activities. And lastly, applying dose-sparing techniques during radiotherapy planning, including breath hold technique and, if possible, proton radiotherapy. Chapter 4 presents a prediction model for the differential diagnosis of pneumonitis. Immunotherapy has become the standard of care in patients with advanced stage non-small cell lung cancer since 2015, and it has significantly improved the quality and also the survival of the patients. However, unfortunately, it can cause immunotherapy-induced pneumonitis in 8% of the patients. And in that case, immunotherapy should be stopped immediately, and high doses of corticosteroid will be administered to remove the inflammation. On the other hand, 10% of the patients are subjected to other types of pneumonitis, including bacterial infection, radiation pneumonitis, progressive disease, and so on. And in that case, immunotherapy can be continued without any problems, and the patient will receive antibiotics. However, due to similar radiological patterns, it's not always possible to make this differential diagnosis. And if other types of pneumonitis is misdiagnosed as immunotherapy-induced, then the patient will suffer from unnecessary cessation of immunotherapy and also bleeding due to high doses of corticosteroid. In contrast, if immunotherapy-induced pneumonitis is misdiagnosed as other types, then the consequences is even more serious and the patient will be at risk of death due to untreated immunotherapy-induced pneumonitis. Our hypothesis was to test whether radiomics or the quantitative measures that are extracted from these diagnostic CT scans can help us to make this differential diagnosis. We considered 7 regions of interest, including the whole lung mass and 6 cubical and spheroidal ROIs surrounding the seat point of the inflammation, and we found that while the clinical factors didn't provide significant predictive value, the radiomic model that was built based on the 75 millimeter spheroidal ROI provided the best predictive performance. And it correctly diagnosed 10 out of 12 patients for whom there was no conclusive radiological judgments. In Chapter 5, the aim was to develop a prediction model to estimate the risk of brain metastasis in patients with non-small cell lung cancer. The standard treatment in stage 3 or locally advanced non-small cell lung cancer is concurrent chemoradiation, which combines chemotherapy and radiotherapy at the same time to improve survival and also the progression of the disease. Even with this intensive treatment, 30% of the patients will develop brain metastasis. And the treatment options at this stage is very complicated. The patient may receive surgical resection, brain radiotherapy, or systemic treatments. Or if none of these treatments are possible, then the patient will be referred to supportive care to only focus on the quality of life. In either cases, the overall survival of the patient will be almost 1 year. Prophylactic cranial irradiation, or PCI, is a preventive treatment that can be used to reduce the risk of brain metastasis. However, its application requires a careful balance between potential side effects and benefits. If the patient is at high risk of brain metastasis, then the PCI can be recommended to reduce the risk. On the other hand, if the patient is at low risk, then the PCI will lead to unnecessary cognitive disturbances without sufficient clinical benefits. In this chapter, we investigated whether the gross tumor volume of the primary tumor, the involved lymph nodes, or the summation of both include some imaging biomarkers that can help us to estimate the risk of brain metastasis. And we found that the radiomic model that was built based on the gross tumor volume of the lymph nodes provided the best predictive performance. With a negative predictive value of 95%, we believe that this prediction model can be used as a useful screening tool to exclude low-risk patients from future studies. In Chapter 7, the aim was to develop a prediction model for radiotherapy-induced neurocognitive decline. Primary brain tumors, depending on the size and the location, can be in close proximity to critical structures that perform vital body functions, including the brainstem, which connects the brain to the spinal cord and is mainly responsible for breathing, heart rate, and sleep cycles. The cerebellum, or the small brain, which is responsible for balance, coordination, and motor skills. the hippocampus, which plays the key role in memory and learning functions, the hypothalamus, which regulates appetite, body temperature, and other hormonal balances, and lastly, the pituitary or the master gland, which is responsible for stress reflexes and also reproductive activities. So as we can see here, the radiation field, which is targeting the primary brain tumor, will unavoidably affect all these structures. And that's why we see that 50 to 90% of the patients will experience neurocognitive decline after radiotherapy. To objectively measure the neurocognitive function of the patients, we use 3 instruments, including the COVA, or the Controlled Oral Word Association, which quantifies the verbal fluency by asking the patient to list as many as words that he can remember, starting with the specific letters within a time frame of 1 minute. The HVLTR, or the Hopkins Verbal Learning Test, was used to measure the immediate and delayed memory, as well as the semantic recognition of the patient. And lastly, the TMT, or the Trail-Making Test, was used to quantify the executive function of the brain. Reliable change index was calculated to identify decline events, and 3 prediction models, which included different clinical and dose volume factors, were developed to estimate the risk of neurocognitive decline at 6 months, 1 year, and 2 years after brain radiotherapy. In conclusion, the developed prediction models have the potential to improve diagnostic accuracy, treatment selection, and follow-up management. Radiomics has the potential to identify useful imaging biomarkers that are not visible to human eye, yet they can be used to improve diagnostic and prognostic tools. Integration of clinical, dosiomics, and radiomics data can improve personalized risk estimation. And lastly, the prediction models have the potential to offer valuable insights as the first step to proactively address patients' needs. Following research lines can be considered as future directions. First, integration of other omics data, especially genomics and pathomics, which can help us to capture a more comprehensive view of the biological process underlying the patient outcome. Second, using nonlinear machine learning algorithms can potentially help us to improve the performance. However, this often comes with the trade-off in interpretability of the model. Third, since the landscape of cancer is constantly changing, continuous learning and validation is essential to make sure that the predictions are not based on expired associations. And lastly, clear accountability frameworks are required for the successful implementation of these models into clinical practice. And with this, I would like to thank you for your attention, and I will give the floor back to the prorector.
Thank you for your clear presentation. The opposition will be opened by Professor de Ruijsen, Professor of Radiotherapy in Maastricht University.
Thank you very much. Thank you very much for this great thesis. I want to congratulate you, also your whole team, of course, also your family. And also congratulations for this great presentation, which also stresses the broad scope of your thesis. But I'm here to ask questions, and I want one of the paronyms to read proposal or proposition, number 7.
AI predictive analytics can transform clinical decision-making and healthcare delivery, emphasizing the necessity of ethical guidelines and continuous model validation to ensure its safe and effective use in augmenting human judgment in medical practice. Dixon D. et al. 2024.
Thank you. Actually, I want to focus on 2 parts in proposition 7. First is AI, and the second part will be then continuous model validation, so not the other items, because there's a lot of data in there or ideas in there. My first question is, do you really use AI in most of your chapters? Because most of the time you're using some kind of logistical regression analysis. And do you call this AI, or do you have something else in mind looking to the future?
Highly esteemed opponent, dear Professor de Ruijsen, thank you very much for your kind words and also for your question. In my thesis, for some parts, mainly I used regression as clinical prediction models, which we can consider as a traditional or classic machine learning. But there were some parts like automatic segmentation of the heart. We use some AI products But in general, I would say continuous evaluation is necessary for all kinds of products that are developed either by machine learning or the novel AI techniques.
Yeah. But let's focus now on my question actually about AI. Do you think that in the not nearby future, but already in the present, I think, that like logistical regression analysis, which can be considered classically as machine learning, but is this the way to move forward with AI, or what type of newer or other techniques in AI should be used in order to improve prediction models?
I believe in my thesis I mainly use regression because it was important for me to make the results interpretable in terms of the associations and the direction of the associations. But I believe that we can use further methods to improve the performance. For example, in chapter 5, we can definitely use our finding which told us that radiomics on the gross tumor volume of the lymph node is already predictive for brain metastasis. But then the positive predictive value was not that good. I believe if we can use some deep learning methods, but then only focus on the lymph node, it can definitely improve the performance.
Mm-hmm. And beside the performance, you mentioned, of course, radiomics, but then the explainability of radiomics, for me at least, is really very, very low. So don't you think that is intrinsically a problem with radiomics?
Regarding the imaging biomarkers, I would prefer personally to start with radiomics because at least we know that each feature, what does it represent and how it is measured. Sometimes it works very well. Maybe in some cases that only the size of the tumor is the driving factor. Radiomics can work very well and it is interpretable to some extent. But then if it doesn't provide the performance that we want, we can move to deep learning. However, it will be complete black box, even worse than radiomics. But if that works very well on prospective patients, then we can consider it for clinical use, maybe.
Okay, thank you. And the second part in Proposition 7 is continuous model validation. Now, to make a model, most of the time, you and many people use what is existing. So basically retrospective. It may be a prospective database, but it's more or less a retrospective analysis on existing parameters or images or whatever. Is this also the way you envisage that the prediction model field should move on? And the reason why I ask it is that if you have already a parameter in your electronic medical file, that implies that we already had an idea why we have this parameter. So basically, will you find new parameters, maybe in images, but for the rest? Or is it just a circular argument or a circle where we are now in? That is, we find better models, but we are still stuck to an AUC of something like 0.70 or something. And we don't find new things because there's no new parameters by definition in the existing data, because otherwise we would not already have chosen those parameters to be part of the electronic medical file, for instance. So do you have ideas for the future? Not necessarily for your thesis, but what's your vision for the future to tackle this problem, or do you think it's not a problem?
Thank you for raising this important concern. Yes, I believe that any types of AI product, including the clinical prediction models, need to be continuously monitored because it's not only about the performance of the model, but it's sometimes maybe the pattern of the patients or the treatments change over time, which may lead to drift of the performance. So if we have some continuous monitoring of the performance and we see that at a certain time it starts to drift, then we can take a more look on what's the reason. Is it the model that is expired, or there are some new features that needs to be added, or maybe we need to recalibrate it on the patients because certain treatment has been added to the guideline, and so on. So yes, I think continuous monitoring with performance measures is the easiest way to go. And as soon as we see that it's declining sometime, then we can look for the reason.
I fully agree with you, and I think this is also one of the advantages over randomized studies, for instance, to use models. But you avoided to answer my question, because my question was, can you think about methods to have new parameters which may also add to the prediction, or are you still sticking to the existing parameters?
No, I would definitely, if there is any new candidate predictor that we can add, we can always try a modified version of the prediction model or the AI product with additional data.
Could you envisage that you use AI to find new parameters?
There are some exploratory analysis techniques that can help us to identify, but then rigorous analysis is required, and also refining by the clinicians to make sure that those findings are relevant.
One last short question, that is, do you think that validation always implies external validation? Or you think, well, internal validation is good enough because I'm sitting in front of patients from Maastricht and I'm not interested whether the model works somewhere else? Or do you totally disagree with that point of view?
Yes, depending on where the model is going to be used, I believe different requirements is needed. If the model is going to be locally used at Maastro, I would just suggest to perform a temporal analysis on prospective patients, just to make sure that the model is also working good on the new patients that haven't been seen by the machine learning algorithm. But if it is going to be used also in other centers, then yes, external validation is necessary, and that's the first step to go.
Thank you very much. I give the word back to Mr. Prorector.
Thank you.
Thank you. The opposition will be continued by Professor van der Bent, Professor of Neuro-Oncology, Erasmus MC. Thank you for coming to Maastricht.
Yeah, it's a pleasure to be here. Mrs. Candidate, I would also like to congratulate you and include your mentors with that, with a beautiful thesis, nice work, good scientific work. So I'm very happy that we can see you in Rotterdam over the coming years. Of course, Rotterdam is the place to be when it comes to science. I would, and you will not be surprised by that, I would like to go to chapter 7. And maybe one of your supporters could read proposition number 3.
Retrospective data, despite their inherent biases, are hidden gems full of potential insights waiting to be decoded from this thesis.
Yes. That's the beauty of fashion, that we think that we can just start digging and we'll find something. The question is, can we find something if we don't know what we are looking for, or are we always looking for something that we have in the back of our minds? So if I go with you to chapter 7, what do you think is what was your main question when you were setting up the research for chapter 7?
Highly esteemed opponent, thank you very much for being here in person and also for your kind words and for your question. In chapter 7, the aim was to mainly predict the patients that will be at risk of persistent decline. Even though the application of the clinical action that we can do for them is still under debate on how to preserve the neurocognitive function or how to reverse the decline. But our aim was to first identify the patients that will be at risk of persistent decline. We had limited data, unfortunately, because primary brain tumor is rare, rather. But so if I had more resources, I had more data, I would have developed a model which would only focus on the persistent decline, because neurocognitive function is by nature dynamic and the patient might improve without any actions. But there are patients that will decline over time, and they are the patients that need actions or need our attention.
Yes, and if I read your work correctly, and you mentioned it also in the discussion, where you state bluntly that our results highlight the low-dose radiosensitivity of brain tumor tissue. So radiation therapy is bad for the brain. then you enter a lot of patients with a lot of clinical variables, no less than 58 variables on a total group of 200 patients, just over 200 patients. With that amount of variables, you're going to find something.
Yes,
The chances would probably be less than 1% that you don't find anything.
No.
So you start digging and yes, you find something. So can you really dig without having some idea what you're going to look for?
I do agree with the with the comment, because that is the main point of carefully pre-selecting the candidate predictors. But we actually performed a literature review to try to only focus on the predictors that have been published.
Which was absolutely great. I think one of the main tables of your work is not in the book. It's not even in the manuscript as published in the journal. It's in the supplement. It's table S2, which overviews all the factors that could have been considered, which is really a nice paper because it gives a lot of insight in what you have been doing. So if you go back to that supplement, there was something strange in there. And we'll go back to the supplement because your findings are not supported by a lot of the day-to-day clinical things that we see. Your findings are that most of the patients, or half the patients, develop cognitive disturbances. If you look at low-grade glioma patients, work done by Martin Klein in Amsterdam, but also with Jaap Jaspers from our radiation therapy department, shows that most of the patients do not develop cognitive problems in the first months after radiation therapy, and yet you find this. Can you explain why your findings deviate from the findings of other groups?
The neurocognitive assessment at Maastricht was performed at 3 time points, 6 months, 1 year, and 2 years. So we didn't have really data on early decline.
That's early decline. We would call that early decline. We would call late decline, we would call after 8, 9, 10 years.
Okay.
So with Martin Klein produced data on the first 1, 2 years, Jaap Jaspers on the first 4 or 5 years, and they don't see decline. How's that?
Maybe the differences in the protocol of the radiation, maybe the population or difference.
Then we have to discuss this issue with your radiation therapist. That's a serious thing that you now put on the spot. Okay, I'm going to the supplement. You have in the supplement, you have all the variables and you provide the data on 6 months, 1 year and 2 years. And then I look at WHO grade 4 tumors, I look at glioblastoma, and you have an OR, I think the objective risk. In the first 6 months for grade 4, it's 10.1, and for glioblastoma, it's 6.7. But at 2 years, this 2.1 goes down to 0.8, and the 6.7 goes down to 0.6. So apparently, the glioblastoma patients are doing better over time.
Thank you for your question. Again, I think this finding is maybe related to the number of the patients, because at 2 months we had very, very few number of glioblastoma patients that survived until that time. Yeah. So, and we had the neurocognitive function. That's maybe an incidental finding, but the univerbal analysis per se is not a good way to interpret the results. That's why we perform multivariable analysis to make sure that the associations are meaningful.
So we have something about the disease. If I ask the same question for grade 2, then the OR is 0.9 after 6 months and is 1.6 after 2 years. So there's a huge difference between glioblastoma and grade 2 tumors. Would you agree?
The only thing that I can suspect, but I need to go back to the data, of course. I think the only issue can be the limited number of the patients. So that's why I don't really trust the findings in the univerbal analysis that much.
It's not fair. I did not warn you that I was going to read the supplement. I agree. I think the basic issue here is that you lumped all the patients in one box.
Yeah.
And maybe when it comes to glioblastoma, you haven't been looking at the effects of radiation therapy, so my colleague of the radiation therapy department is off the hook, but you have been looking at the disease. And we know that many of the patients with the glioblastoma are progressive after 6 months. So could it have been that you have not been assessing effects of radiation therapy, but effects of the disease?
Yeah, that can be, because again, glioblastoma is something that we also received the comment from the reviewer of the journal that
so
maybe
my
a
colleagues
subgroup.
at the other side of the table, I have my confession. So then it comes back to what you have in your proposition 3. You start digging, but if you start digging with a tabula rasa without knowing what you're looking for, you may end up with ending the wrong conclusion. What I like very much about the setup in Maastricht is that they have been collecting all these data on neurocognitive testing using a test battery that is widely accepted. But if you start mixing up tumor entities, you may up ending conclusions about the tumor and not so much about the treatment or about the disease in more broader perspective, like intracranial tumors.
Yes, I do agree with you that more specific analysis on the subgroup of the patients, considering the WHO grade, might be more useful. But unfortunately, in terms of prediction modeling, because the number of patients were so limited, we had no choice. We had to pull them together. However, yeah, I declare that as a limitation.
Mr. Dean, I rest my case.
Thank you. The opposition will be continued by Professor Tacchetti, Professor of Anatomy at the University Vita Salute San Raffaele in Milan. Thank you for joining via the internet.
Thank you for the invitation. And I'd like to congratulate the candidate for the nice work presented and the really extremely interesting thesis I had the chance to read. Thank you very much for that. I have two questions. One is quite specific on one of the papers presented on chapter 7. And the second question is a little bit more broad on approaches, general approaches. So the proposition I'm going to refer to is the proposition number 2. And I would like please to ask someone to read that proposition, please.
Amidst the latest advancements in AI, clinical prediction models can provide valuable insights as the initial attempt for addressing the patient's need proactively from this thesis.
So in the interesting paper, actually you just discussed on chapter 7, predicting the risk of neurocognitive decline after brain irradiation in adult patients with a primary brain tumor. You correctly refer to studies demonstrating that higher education is protective against radiotherapy neurodecline side effects. And you used in the paper the 3 tests for cognitive analysis. One is the COA, lexical, the HAVLTR, which is for a memory test, and TMT, which is for more spatial orientation. And the conclusion of the paper is that there is a decline basically overall in the many types of cancer clustered together and which were actually located in different positions. So my question is, would this analysis provide a better results if the 3 tests would be performed ahead as it has been done, but the patient clustered according to the performance to the 3 tests? So would patients that had higher ability in COAR or in the memory or in the TMT being clustered in grades of performance, would those and relate those activities to the site of the tumor, which would effectively going to affect specific functions of the brain? So would that clustering of the patients compared to the outcome after the radiotherapy, would have provided a better insight on the neurodecline, taking into consideration both the specific activity tested, the specific site of the tumor, and the outcome.
Highly esteemed opponent, thank you very much for your compliments and also for your questions. Yes, that was something that I would have loved to do if I had more patients. And I think the more specific we are on the target population in terms of the stage, the treatments, and also the education level of the patients, we can get more valuable results, of course. But unfortunately, I had to pull them together. And also another issue is considering all the tests. So in this case, we considered decline in one test as the decline or between them, which is also not a specific result in terms of the outcome. Maybe if we only focus on the decline in each of these domains that we have measured, then also the results would be more clear and beneficial. Maybe that's also why we found that more than 50% of the patients developed decline, because it was the summation of all domains. But yes, I do agree with you fully that more specific analysis would have given us more valuable results, of course.
Yeah, thank you for the answer. And I think a part of the answer was already given in the previous answer, respect to the distinguishing actually the effect due to the cancer from the effect due to the therapy. So I would like to switch to the second question. The second question is more an approach-like. So how do you envisage the differences between advantages and disadvantages in using radiomics versus deep learning in the AI analysis of diagnostic imaging?
Yes, I think we briefly discussed it in the first question that in terms of imaging biomarker, we have lots of options. We can start with radiomics, but also we can directly go to the deep learning methods, which are in turn also lots of different techniques and different architectures that we can use. But I started with radiomics because they are at least interpretable to some extent. We can understand that what are these features representing and what are they measuring. And to be honest, in chapter 4, we found very acceptable PPV and NPV by the radiomics only. So, but I think it would have given us better insights if I would have also tried some deep learning techniques. But there are some studies that have compared the both approach, and that's mentioning that using deep learning does not necessarily guarantee a better performance. It really depends on the clinical question.
Okay, I think I'm satisfied, and I leave the podium to the dear prorector.
Thank you. The opposition will be continued by Dr. Feiten, Assistant Professor of Clinical Data Science at Maastricht University.
Dear candidates, my congratulations to you and your promotion team with this this very interesting thesis. Lots of technical work that you have been doing. What I would like to start with is the PROBAST evaluation that you used in chapters 2 and I believe chapter 6 in your reviews, where you reviewed the prediction models. The first question that I had is more a general one as to why you selected this one, because I know there are many, right? There are many of these evaluation tools. What made you go for this one specifically?
Yep, esteemed opponent, thank you very much for your kind words and also for your questions. At the beginning, I chose another tool that I was more interested in, but then when I submitted the paper, I received the feedback that the PROBAST is the most common one, and it has specifically is designed for the prediction models in literature reviews. So they suggested, and I followed the suggestion.
Okay, that's a good reason too. Yeah. So what I meant, or what I found in figure 2.5, for instance, That's the one with the pluses and the minuses, where you compare all the models based on the ProBest evaluation.
Yeah.
I was honestly not surprised, but still, disappointed that most of these studies are very poor quality, right? I was curious to hear your opinion on what you think these researchers, and I guess us as well, because we do these things as well, what are some low-hanging fruits that we should do to really improve the quality based on, what you found in chapters 2 and 6?
Yeah. Well, according to ProBest, we need to focus on 4 domains, which is participants, predictors, outcome, and analysis. One of the reasons that most of the included studies were low quality was that maybe the aim of our review was to identify the published risk factors in the paper so we can use them in our analysis. Maybe they didn't really intend to develop a prediction model. They just wanted to find the risk factors and report it. So that's one issue. But generally speaking, I would say the most challenging domain was analysis, where they didn't report their results completely and they didn't evaluate their model sufficiently. So that was the reason for the low quality scoring.
So reporting is the thing here that needs to be improved?
I think
Not
so.
necessarily the method itself, then, in your opinion?
The method also, yes, because external validation is always missing, almost. So that's one issue, and that is necessary in terms of ProBest. I didn't have it in some of my chapters either, unfortunately.
Yeah, we'll come to that.
But I think, validation is the most challenging item.
Is that also the reason why in some of the other tables in this chapter, there's a lot of stuff missing, right? In terms of accuracy reported, for example, in equations and stuff. Yeah. Okay, that's what I figured. So now what I would like to then do is actually go to chapter 8, and I believe the same goes for chapter 7, but correct me if I'm wrong. One essential part, I think, of the ProBest evaluation is that you do not do univariate pre-selection of variables, right? I believe this is actually what was done in chapter 8, and I believe also in chapter 7. So, which is fine, there's many reasons why you could or should do that or should not do that, but I was curious to hear what your reasoning for that was, right? Because you kind of make the point in, I think, your introduction and discussion, and also in these review chapters, that is really important, this kind of stuff, right? External validation, following these guidelines. And then in the papers, some of these steps are missing. So I'm just curious as to why you decided to do some type of univariate selection before you made the models. Yep. And what you think of that looking back. Maybe your opinion has changed since then.
Yeah, thank you very much for your interesting question. It seems that you have read the whole thesis with so much careful, because I didn't expect you to notice this. But
Sorry.
anyway, in chapter 8, yes, that was the first time actually that I was analyzing radiomic features.
Right.
And I hadn't developed my pipeline yet, and I performed univariable analysis. But if I could go back, of course, I would have addressed all these issues related to univariable analysis now. And probably if a journal asked me to review the statistical section of this manuscript, I will probably reject it now. Yeah.
Okay,
But,
that's good. I mean, it means you've learned, right? I still have some time, so let me look for another question in my list. And maybe going back to chapter 2 and then also chapter 6, I guess. One thing I noticed was that a lot of these, when you have the table with the prediction models, right? I noticed that most, if not all of them, have equations, right? Which you write down, right?
Yep.
So that would, I would then assume that these were all also logistic regressions, right? And this comes back to, I guess, Professor de Ruijscher's comment or question, right? It seems that they've also done stuff like logistic regressions, right? So this seems to be like the, how do you say that, the not the golden standard, but sort of the assumed thing to do, right, when you're doing clinical stuff. Do you think this is a good approach, right? You mentioned explainability, but there's lots of explainable AI methodologies nowadays that can help you, with maybe more complex and maybe more robust methodologies, right? But it seems still everyone goes with logistic regressions, right? So I would love to hear your opinion or exchange thoughts on what you think of this.
Yes, I do agree, even though that I mentioned that almost none of the included studies really developed a model. They just wanted to find some risk factors. But still, again, I would start with prediction models because they are the most interpretable one. And then once you're sure that the associations are meaningful and relevant, you can use other machine learning algorithms or AI techniques. Otherwise, it's really not, there is no guarantee that all these new AI techniques can find some unrealistic associations, which can also provide some good performance, but you don't never understand what is going on inside them. So I would suggest to first identify the most relevant factors, and then if there is a finding or if you haven't got the performance that you wished, you can move to other machine learning techniques or AI techniques.
So your suggestion is still start with logistic regression?
I would start with logistic regression, yes.
Okay, fair enough. I give the word back to the Director.
Thank you. The opposition will be continued by Dr. van Elmt, Assistant Professor of Implementation of Artificial Intelligence in Healthcare. It looks like we have a lot of time for your discussion.
Yeah, that I would like to easily fill. Thank you very much, Mr. Prorector. Dear Ms. Candidate, first of all, congratulations to this enormous amount of thesis and also your supervising team. If I count correctly, there are 9 papers actually submitted and accepted, or almost accepted in this thesis over the past 4 years, which is actually quite incredible. I think over 3 disease sites, you could easily have the basis of 3 PhD theses. So actually that's a big compliment to you, what you have been achieving over the past 4 years in such a short period. Currently, as you know, and you might have expected from me, is that we are evaluating these models in clinical practice. And we want to assess the usability and the added value to our patients to see where it really can advance. And there's also what you say in proposition number 2, where it provides insights and attempts to increase patient treatments. We do this in the broad sense. So we integrated your models, we put a user interface around it, we have them hooked into an electronic health record, so that's easy accessible to our doctors. And we launched this actually last year. So for actually 3 of your models, or 2 or 3 of your models, they can actually use it for evaluation purposes in our clinic, which is a good, which also shows a little bit about the work you've been doing. The problem I have now is that they come to me with all the questions. Which is okay, that's fine, but I want to challenge you a little bit with the feedback and the comments and the concerns I get from them now that we are putting them in there for real. So my first question is actually, how would you give advice to a doctor that is in front of a patient and wants to use your model, whether he can actually use the model for that particular patient? How would you instruct him, or what would you advise for him if he asks, can I use this model for this patient that is in front of me? How would you react?
Esteemed opponent, thank you very much for your kind words and also for your question. Depending on the chapter, I would give different answers. In chapter 3, I would really highly suggest it to use it because we had enough data, I had enough time to perform a robust analysis, and the findings were so clinically relevant, and the performance also was good. So I would suggest to at least perform a pilot study on some prospective patients to see how the model works on them, and then give it as an instrument to the clinicians and the patients, whether they want to take it or not. Because I first need to be sure that the model is working well on the unseen patients, because I didn't have the chance to test it on new patients or external patients. So I would first perform a pilot study to identify to recalculate the performance measures, and then if I want to give you a solid answer, I would suggest chapter 3 and chapter 4. To some extent, chapter 5 also is nice to be evaluated on new patients.
Okay, so I see you hesitating a little bit for the chapters. Can you explain a little bit why that is?
The main reason is the data. I had limited data. I didn't have patients from other centers, and it really was a big challenge to be sure about the performance of the models. Yeah, but regarding if I just want to make a robust conclusion on which model is ready to be used on prospective patients just in Mastro, then I would say, yeah, chapter 3 is already good.
Okay, let's take chapter 3 then and the rest of the questions, because that you're most confident in. So we did some sort of prospective evaluation, and it turns out to be in line with the model. Suppose we've done that. And then the individual patient comes in front of the doctor.
Yeah.
Should he do something then, or can he just use it? A stage 3 patient comes in. Should he check something? Is it always applicable? Should he do something or just use it as such?
I think considering the clinical application of performing regular follow-up with ECG after radiotherapy, we can just calculate the risk and share it with the patient. This is the risk that is probably you are going to develop a new onset atrial fibrillation after radiotherapy. Do you want to come to some visits to perform ECG so we can detect it early and treat it on time? Then I would leave the decision to the patient because, yeah.
Okay, so I said we validated this. We did this on a Mastro cohort. The patient just tells me that they just moved from Rotterdam to Limburg. Can we still use it?
That's a challenging question because it again goes back to the external validation.
But you said we don't need it. If we do a prospective evaluation on Mastro data, we don't need external validation.
Yeah, but the patient is coming from other centers or no?
Well, he just moved.
He just moved. I would still go for, because performing an ECG is not an invasive test, and it captures lots of cardiac abnormalities beyond the atrial fibrillation. So even though if it's false negative, it's still not a huge cost for the patient, even though, yeah, we need to consider lots of factors. If the patient is too old, cannot perform lots of visits, and is not really comfortable with the ECG, that's why I will leave the final decision to the patient.
Yeah, so there's, for this model, a low risk if you cannot do really harm in this patient by giving him
If we consider follow-up with ECG, yes.
Then the next question comes, so he comes from Rotterdam, this patient, and we can use it, and we have some missing data in the model. How should the doctor use that? So there are like 5 or 8 parameters that he needs to fill in, and he doesn't know 2 of them. What should he do?
There are several things that we can do. We can...
I'm in front of this patient. I need to do something. I open your model. I have this nice user interface.
Yeah, sure, especially because there are some lab measures in there, and some patients come without the letter from the laboratory. We can perform some statistical methods. We can find the nearest neighbor to calculate or to impute the missings according to the similar patients from the data set that we have. Or we can ask the clinicians to give us some relevant clinical factors that can help us to impute this factor, and we will do that in the AI tool. Or if none of these happens, then we can exclude the variable from the model and give you another version without it, which I don't suggest, but that's also one method that some people use. I would go for the nearest neighbor in the data set that we have.
Okay, so I need a little bit of your help then to get this into the clinic. Would it be an option, because that's how we interpret it now, is that we just calculate with and without this factor, or put a certain factor to yes or no previous cardiac conditions? Is that a viable solution for now, that we fill it in 2 times, because we don't know, we fill the extremes in and get the chance of the toxicity or the prediction that you want? Or do you think stop doing that?
If it's a binary variable, yes, it can be, but for some measures like the creatinine level, yeah, that cannot help.
Well, we can take a very low and a high one.
Yes. Yeah, that can be a nice if we don't have anything else. Yeah, but just keep in mind that we can help you with some statistical methods.
Okay, but okay, thank you very much for that. That's really appreciated. So then we get this prediction, and I want to go a little bit with the interpretation for that. So the patient is at risk, which you showed for atrial fibrillation. However, if I read in your model correctly, you typically, and you do it in chapter 3 and also in chapter 8, you make your model based on the cutoff value that you define by the Youden index on the AUC curve. Why did you actually choose that particular cutoff?
This is also an important question. While we use the maximizing the Youden J index, we are making a very rough assumption that the cost of false positive and false negative is equal, which is almost never the case in clinical practice, right? The more optimal method is to give different weights to false positives and false negatives, and draw the decision curve analysis with expected cost rather than just net benefit. But then the question comes how we are going to quantify the costs related to each. This can be different per patient, different per clinician, different per center, insurance companies, and everything. So that requires a very huge study, let's say a cost effectiveness study, to give us a number that we can give you a...
I will come back to the cost effectiveness later, but I first want to know why, because I understand your Youden index is like an average. All the doctors I talk to, they either want a high specificity or high sensitivity because that eases their clinical decision making.
Yeah.
Is that something, should we then retrain models or remodel them to have these cutoffs in future, or do you think still stick with the Youden index or go with this high sensitivity or specificity according to what the doctor wants?
Yeah. This is also one of the comments that I received from the reviewer of the journal. That's why I put a supplementary table with all possible cutoffs and their associated PPV and NPV. So each clinician, at least based on his opinion, can consider as a different threshold for categorizing patients into low risk and high risk. So we have left the decision to the clinician. But Youden J index is a common method, a statistical method, but I wouldn't really say that the result that it gives us is really the optimal threshold. It really depends on the clinical application and the actions that we are going to take for the patient.
So what would you choose then for chapter 3 for the atrial fibrillation? Would you choose something different or would you stick with it now? Because we still can change it, we're implementing it. So.
Yeah, I think the clinicians can make the best judgment on this. Okay. So that's, I would refer them to the table. So when they are happy with the PPV and NPV, they can choose that cutoff.
Yeah, and I like actually that answer because that makes clear that it is an interplay between clinicians and the data scientists to actually advance the field forward. In chapter 3 then again, we look at some follow-up actions that we can take. So I quote from your paper, it says the model has the potential to help clinicians. Post-RT active screening, lifestyle recommendation will be advantageous, or RT adjustment, so that we change radiotherapy delivery. Is that really something you want to recommend?
Well, if we have the choice between photon and proton, and if we can really spare left atrium or a right atrium, which is close to the sinoatrial node, I would suggest to go for proton therapy, if that is possible. But if I wouldn't suggest to shift the dose in photon radiotherapy. I'm just talking about choosing between photon and proton. Because if you shift the dose, then you are going to harm the other organs at risk, and you are interfering all the current guidelines, and I wouldn't suggest that.
Yeah, that's a very good remark that we actually put in the training for our doctors as well, that they don't take because it's a slider, right? You can, when you fill in the model, it gives you a risk at a certain heart, left atrium or right atrium dose, so that they shouldn't interpret that as something that they should modify. So that's a careful comment actually while using this model. And also I saw in your slides only 11% of the patients actually developed atrial fibrillation, which it was the largest of all the cardiac events. But then doctors asked me, what about the others? So what should we do?
At the beginning, I pulled all these cardiac events together, and then I received the comment that you have to be specific. So that's why I went for atrial fibrillation. If it's up to me, I would say my personal preference is to pull them together still, because all these cardiac events that I mentioned can be detected by an ECG. So if you are really going to perform an ECG screening, then pulling them together is not a big issue, even though, the results won't be that specific, but we are just focusing on the application of the model. Mm-hmm. For now, I would say, again, with this atrial fibrillation, we can perform a screening, and if we find that the patient has some, like myocardial infarction in that ECG, so we can also refer that patient. But yes, the model only focuses on atrial fibrillation for now.
And that's also a good remark that we use it in a prognostic way and not in a predictive way, because it has a lot of features that you can still choose on as a clinician, but don't let the model drive you in these choices to make a decision based on the model parameters. Then coming back to your cost-effective analysis. So currently these models are considered to fall under the medical device regulation, the MDR. The problem I have with implementing is that we need to put up quality management systems, etc., to get them out. Typically, estimates are between 50,000 and 100,000 euros to get a model certified. That are what current clinical costs are. You have developed 3 or 4 of them. How should we do this? Or how should I select which model I need to spend my money on, and how are we going to actually prove that it is worth that money?
How much money do you have?
Let's say I have this 100,000 euros that I want to go, or maybe double. I have 200,000, so I could go through this with you if you want. What should I do?
I would suggest with chapter 3 still.
Okay.
Yeah, we can go for the atrial fibrillation model.
Fariba Tohidinezhad, the time appointed for defending your thesis has passed. The degree committee will now withdraw to discuss the quality of your thesis and your defense. And I request you and your company to await the results of our deliberations and our return in this room.
Thank you.
All right, please.
The PhD defense has now ended. The degree committee will debate the candidate's performance behind closed doors. This process usually takes about 10 minutes.
Long road to the south side. 10 miles in my rearview mirror, I know what it felt like. My goal's only getting clearer, east side to the west side. No place like home, if there's questions that you've got, go the extra mile and die. On the line, I know you know that I can't read your mind. Years can't fly by now, don't waste all your time. Cause I'll go the extra mile. Long road to the south side, 10 miles in my rearview mirror, I know what it felt like. My goal's only getting clearer, east side to the west side. No place like home, if there's questions that you've got, go the extra mile and die. On the dash, got my laces tied. Long road, I don't waste no time. Break rules because fate decides. With the team and we chase the light. I make a move, fall down, shake it off. I hate to lose, bad branch, break it off. No room for negativity, praise and love. Prepare for deep part cause we're taking off. It's the mileage, traveling so far from home. Gathering knowledge, other connections. I put the time in to get everything I ever hoped for. It's a challenge and we all in. It's a better future that we go for. And even though these nights seem long, I know that I am never on my own. Know you've won the battle once you've grown. South side, 10 miles in my rearview mirror, I know what it felt like. My goal's only getting clearer, east side to the west side. No place like home, if there's questions that you've got, go the extra mile and die. Long road to the south side, 10 miles in my rearview mirror, I know what it felt like. My goal's only getting clearer, east side to the west side. No place like home, if there's questions that you've got, go the extra mile and die. fly by now, don't waste all your time. 'Cause I'll go the extra mile.
Fariba Tohidinezhad, the degree committee here present has assessed the quality of your thesis and your defense. In view of its positive verdict and taking into account your previous qualifications, the committee has decided to grant you the degree of doctor. Professor Dekker is authorized to confer upon you this academic distinction in accordance with Dutch university custom. I invite your supervisor to now take the floor.
All right, please.
Do you promise to work in accordance with the principles of scientific integrity at all times, to be careful and honest, transparent, independent, and responsible? Then by the authority vested in us by law and in conformity with the decision of the committee here present, I hereby confer upon you, Fariba Tohidinezhad, the degree of doctor, and grant you all rights attached by custom and law. As evidence of this, I now present you with the degree certificate signed by the rector, the secretary, and the other members of the committee, and affixed with the official seal of our university.
So first of all, let me say that it's always a pleasure and an emotion to be back here. I've been working here for 7 years, so more PhD, please, so I can come more often here. So, dear Fariba, dear Dr. Fariba, I won't pronunciate your surname because I do it so well that I want to, to make other people in a shame. But I think the intellectual, and scientific value of this thesis is clear to anyone. And I don't need to dig into the scientific results. However, as you dig into data, I found it difficult, but I managed to dig a bit inside of you, which is much more difficult than digging into data because you've been usually very, a close person and so on. So when people ask me, talking in Milan, they say, is she good? I refer people to page on the acknowledgement 243 when you say, last but not the least, I want to acknowledge the patient with cancer whose data has been so crucial to our research. I see each piece of data not just as a number, but as a part of a life story filled with unseen struggles. And I think this is a message also to us. You've been working with AI, and there's a lot of rubbish going on saying that AI will replace humans. So this thesis also put a human-centered view around, AI. So this is also for us to remember that, we can use numbers, but then at the end of the day, we need to deal with people and patients. I think you make a good job on pushing us to reflect on this. And I hope you can continue and in your future work, again, to use number, but then remember that there are people behind number and people working with this with people. Now, coming here on the plane, I was reading a book which is called Why, it's by David Goleman, an author, and he's saying why emotional intelligence, why it matters than QE, so why did it matter than normal intelligence. Now, the question I had for Goleman is what happens if you have a doctor that brings together a high level of intelligence with a high level of emotional intelligence. Maybe it's a suggestion for a new book. I don't know if you want to help me. But the reason is that you, in your thesis, if we dig into the human part of your thesis, you actually represent some of the characteristics that the author talks about when he says about emotional intelligence. First of all is that you need to understand your emotion. And I know it has been difficult for you sometimes to deal with emotions. And it makes sense because, you come from abroad, living in a country, it's very difficult for defending something that we share. But at the end, you took consciousness of this emotions, and you actually start interacting with people, which is really good. The second characteristic is talks about is understanding other emotion, and understanding other emotion, you have to deal with people that think differently than you. I remember the first meeting we had, you were saying, well, it's not good to talk to these people because they don't understand what they do. They do their clinic and they don't understand what I did. Of course, then you start understanding that we have different views, and I think the discussion in your thesis show that actually you manage, to understand how people can feel when they use a model, when they are not confident, and so on. Even if, of course, your promoter is reminding me that, of course, sometimes your emotions were also very strong. So, for example, you had tough discussion with clinicians. I remember them. You were writing me emails saying, "As I want to avoid this meeting because I don't want to argue with clinicians," and actually, of course, I had to force you and to discuss. But then, you show us as your supervisor remind me that it's important, to stand and show that even if you don't have a clinical background, you still have the right to express your opinion based on scientific integrity. This is what you did in your thesis. The other point is about the motivation. So this author says that people and leaders should have motivation, should motivate others. So your promoters reminds me that when you wrote your application, and this is something that actually I overlooked when I was looking at your application, you said something like, "I believe it is our duty as informaticians to take the most advantage of AI and help our practitioners during the decision-making process when there are unavoidable limitations in resources, time, or treatment modality." So you call your job duty, and this is very important. We have a duty and we have a responsibility in front of our colleagues, but also in front of our patients. So this is really nice, and this is something that maybe might not have been, emerged from the thesis, from the paper, but it is something that I know you've spent a lot of attention. And now I think, looking at my notes, I have to come to the most funny things, for which I don't need notes, as you know, because... So the first point is that you love statistics, so your promoter actually proposed me a Bayesian problem, which says, she was extremely prepared for anything, better than I ever seen in a PhD than another employee. And now this comes the Bayesian approach. Given this personality, working together with someone like Alberto, who has a more Italian approach of organizing things, was sometimes a bit of a challenge for all. So I would like to discuss then after with you and your promoter, this Bayesian statistics. So it was difficult to work a bit because your co-promoter was Italian and disorganized. But I know this was the case, even when you helping, in remember that I had to take a plane, I had meetings, and I even don't know how you managed to hack my Outlook calendar, because everything. But you see, this maybe is part of the informatician duties. Of course, sometimes we were a bit scared, especially when you were so much focused on the future. So you are a visionary. You say, after completing the PhD, I plan to either pursue postdoc placement or work as a research assistant. Now, of course, you chose Rotterdam, as we discussed before. Rotterdam is the place to be, but since I was told that you also like gardening a lot and fashion and things like this, of course, you might think about Milan, where we can offer, fashion and garden. We have nice offices with gardens, and so, if you want to visit us, it will be a pleasure. And with all of that, I think that I want to congratulate you with you anymore. I think it's been also a growing experience for us, for me, and for all our colleagues. Of course, sometimes we are a bit jealous that you move somewhere else, but I think the suggestion I have for you is also that you limit the number of travels you wanted to do for some reason, for example, going to the US because of the visa. But now I think the more you travel, the more people will benefit for your scientific integrity. So congratulations again, and good luck with your future.
I follow your co-promoter, Dr. Fariba. Congratulations, also on behalf of the community of Maastricht University. And you did an excellent job, and I wish you a lot of success in your future scientific career in Rotterdam. Before closing the ceremony, I want to give the floor to Professor Tacchetti for a short word.
Thank you very much, Prorector. I would like to congratulate Dr. Tohidinezhad for the great work done. This is a great achievement. It has, I have to say, this is not the highest and the greatest achievement you have done. The most important and really heavy duty you have passed is supporting and standing Alberto for so many years. So once you have done that, your life is downhill now. I really wish for you a great career. You have all the standing to be a very great scientist, and I really wish you a great career in science. Anywhere you like. Your PhD now, it's a ticket for science, it's a ticket for great institutions, and I really wish you can reach your dreams. And thank you for your presentation, and again, congratulations.
Thank you very much, dear Professor Tacchetti, for evaluating my thesis, and also for my sincere thanks for your kind words. Thank you very much.
Okay, thank you. I invite the audience to go to the rafter for a short reception, and we stay a little bit longer here for some pictures. And with this, I close this academic ceremony.